towards more of an integrated care system, more personalized care system. And that has been going on now for approximately 10 years, and more intensely maybe 7, 8, 9 years ago. There was a kind of a political and leadership power taking form for this shift. And SALAR has a role in this by supporting regions and municipalities in this shift, and to collect municipalities and regions together in this shift. And that is a good possibility we have, because we have both all the municipalities and all the regions, so we can really work on the system perspective a lot. So this picture has been around for 10 years now. And that's one of the points that you always come back to, why we do this shift. It's very much from going from a pretty reactive system to more of a proactive and more health promotion based system. It's going from focus on the organization we run to a more person-centered perspective when we work. It's on going from isolated care and welfare interventions to more coordination, as Eric said, team-based collaboration between municipalities and the regional healthcare as well. And also this going from passive recipients perspective to more active co-creators. I'm sure you have seen this in many countries within Europe, and it takes different forms, but this is kind of the Swedish take on it. And you will also see pretty much of this in Västerbotten, I guess, because it tends to be that in the more rural areas, this is more natural from the beginning. Actually, has to be, yes. So that's very, I think you will have a wonderful trip going up north to visit the system there. As I said, I also work a lot on public health issues and so on, and this is also a foundation we have in Sweden that I'm pretty sure you know, the social determinants of health, you know. Health care is a pretty small puzzle in the whole, you know. We have to work on healthy environments and work in schools and you know, how we build up the society with every town planning and so on. So this is also, like you were talking about before here, which role has healthcare in prevention and health promoting activities? This is a very a discussion, and it also takes form in different ways depending on where in Sweden we land. And I'm sure you will see that also in Västerbotten, that we can co-create much more with the health promoting actors as well in the society. And at the same time we have 8 public health targets, which also you can see healthcare is one of many. We have to look on work conditions, income, housing, health behaviors, education and so on. So this is kind of an easy way of describing the roadmap of this transition we're in. So here is 10 years ago, very much focused on why we're doing this transition and putting the top leaders in this program. So within all our municipalities and regions, there was an agreement of the political arena that this is, we have to go within this road, we can say, which was a big starting point. That within the counties, you know, I'm from Jönköping, one of the counties. We have 13 municipalities, 1 region. They talk together. Why are we doing this transition? How can we do this together? And so it was formed with all 20 or 21, as you say, Eric, counties as well. And now I would say that we have done much of the improvement works. We have some change concepts that we now try to scale up. And I would say that we're in phase 3 right now. So how can we do a good scale up? Not, you know, it's easy to make projects, not that easy to make the long-term effects. So it's much focus on the long-term effects right now. How can we take the potential all the way? And that's the, you know, this is where we should be. I hope to be in a few years. So it was good timing that you came, but approximately a month ago we were reporting to our government, so how is this going? Is anything happening? And this kind of, as I said, SALAR get funding from the government on doing this support work. So it's an agreement, yearly agreement with the government that we support this shift and we report to the government, and that was made in September this year. And then we can see that it's actually not only agreements, there is a lot of improved development and collaboration around patient care and hospital admissions for chronic conditions. That has steadily decreased in all regions actually since 2017. The collaboration, as I said, has strengthened between the municipalities and regions. And there is also, since July, we have a new social act. The social care law is now supporting more of an integrated care perspective. It's more about preventive action, more working on equality, equity, and so forth, which is really good that there is a law supporting that from the social care side. So now it's more of a dance, I hope, than a debate. We have to do this together. All right. Yeah, I will come back to the rest there. So an important way that we support regions and municipalities that is scaling up concepts, and the way we do that is really taking the bright spots from different parts of Sweden that have succeeded on results. Then we connect the people that has done the job to others. They are the experts, not we at SALAR. The people that has done the shift are the ones that coach others. So it's more of a coaching program and connecting people with each other. So we do that on videos, results research, competences, and how to implement the different concepts and so on. So this is a small collection of some of the methods or concepts that are in focus right now in the transition. It's mobile methods, local care teams. I'm sure we'll have a lot on that up in Västerbotten. Maybe we have some focus on that. Home care, like intensive home rehab, enhanced home care. Targeted clinics, we could say, like Eric said. Some have much more proportion of elderly or young. Then we have to mirror that need on the clinic level. Self-monitoring, proactive and need-based screening. There are some counties also working a lot on best possible care for children and their families. It could be interesting to have a look at. So the conclusions are that we have done a mapping. Perfect. A mapping of, okay, where these concepts have actually been implemented and are run like everyday basic, what kind of effects can we see? And then we can see up to 50% resource efficiency combined with major quality improvements for many methods. But then, as you all know, we have to reach that in a national perspective. There is a kind of a break-even point that we need to take, if we can make go from 50% in 1 or 2 counties, then we have to do that shift in maybe 15 other countries to have that real effect on a national level. And we can also see there, as I said, a large unrealized potential in this, of course, just like I said. And there is, like we did in the beginning for 10 years ago, that focus on the highest political level has to be maintained. Have the leaders in healthcare on an everyday basis, leaders in healthcare, schools, social service, and so on, have to meet on a almost daily basis, maybe monthly, to really have this momentum all the way. So much focus on the system leadership and to governance. So what's the challenges? Just a few more slides here. So we can see a variation across the country in this transition progress. There is, even though we see a lot of progress, it's sometimes a lack of financial and human resources. We can see sometimes there are economically pretty old systems that we need to shift to work more as a system instead of each in every pillar. This is pretty sensitive. The power shift in itself. In the places that have succeeded the most, the power is more in the patient and the primary care system. And when hospital care is needed, primary care demands the hospital. That is pretty, power shift.
Okay,
Yeah. So
once more, please.
About
the power shift.
the last sentence.
Yeah.
About the primary care and the hospitals.
Yeah, we can see that where the shift has succeeded the most, the power is more within the primary care unit and the patient, and when hospital care is needed, they demand it to the primary care unit instead of the opposite.
І коли потрібно вже лікування в лікарнях, то вони запитують
So it's a shift of power from hospitals to primary care.
Тобто найбільший зараз фокус і найбільше, скажімо, повноважень саме у системи первинної медицини, ніж вторинної.
Power shift – це перетікання.
Ну, shift – це зміна. От power, бо це таке цікаве слово англійською мовою, це і влада, і повноваження, і сила, і потуга, і що хочете. Є такі як power games, як ігри влади. Тобто тут більше фокус і більше повноважень, і тяжіння саме на первинну медицину.
Потенціал найбільший. Найбільший потенціал.
It's not easy to understand.
No.
Чи це означає
What
зменшення?
does it mean? Like,
Чи це означає зменшення навантаження на лікарні і на спеціалізовану допомогу і перетікання в первинну медичну
More
допомогу?
care is happening in primary care?
Yeah, more care is happening in primary care. But I could take my region as an example. We have 40 different primary care units. 40.
40.
Yeah.
У нас 40 центрів первинної медицини.
So they have worked on a system now where instead of instead of referring the patient to the hospital, they have a straight call actually the hospital within the meeting with the patient.
Вони от приймають пацієнта і відразу дзвонять у лікарню.
So there's more of a timing, more of a,
Тобто це більш вчасно.
it's more of a specialized care. It's not something we send the patient to. Yeah, perfect.
Тепер я зрозуміла, що тобто первинна медицина стає центром тяжіння медичних послуг і медичного догляду. Замість того, щоб лікар первинної медицини сказав, та я це не знаю, у вас складний там випадок, вам потрібно в лікарню і все, позбувся пацієнта. Він навпаки звертається до вторинної медицини і залучає експертизу в конкретному випадку. А пацієнт обслуговується на рівні первинної медицини.
Okay, just 1 minute more. And so this is my final slide there. And so where we're at is really keeping the momentum on system leadership. Go together, municipalities and regions in the same direction, as I said. A lot of focus right now on scaling up successful concepts and methods. Right now it's a lot of focus on the new, as I said, Social Service Act and how we can we have one, as you know, healthcare legislation. We now have a more proactive social care legislation, so now it's timing to go more together.
У сфері соціального захисту, соціальних послуг, і тепер час більше робити разом.
So, that's it. Yes, thank you.
Питання.
Question.
Да, Костя, дай людям теж трохи.
Да. Дякую.
Кажи ти.
Питання. Скажіть, будь ласка, як первинний рівень первинної медичної допомоги мотивується до того, щоб брати на себе відповідальність більше?
So how do you motivate primary care level to take on more responsibility, more power?
Yeah, I would say that
Or what is the incentive for them to take on more?
I wouldn't say that they take on more.
Я б
I
сказав, що
would say that they are the, as we say, the base
Я
of
б
the
сказав,
healthcare
що це
system.
база, основа системи охорони здоров'я.
And being the base is, primary care is closest to the population.
Первинна медицина
They
це те,
know
що
the
найближче
population,
до населення.
And
Вони
so
знають.
it's more on it's not over time we can also see that primary care gets more competence and more finance.
Вони одержують
We can say that from a 10-year perspective we can see
Якщо
that.
дивитися на перспективу 10-річну.
Суть питання в чому? Він же лікар, чи заклад первинної допомоги, йому ж легше, менше часу займає просто написати направлення і відправити в лікарню, ніж взяти на себе, телефонувати, задавати питання, щось робити. Або другий варіант, просто відправити. От чому він бере на себе?
Yeah, but especially now when there is a lot of complex patients, more chronic conditions, patients are needed more of the many competences at the same time. We can see that. So it's been a big strength to put a team approach around the patient. What is the best for you? What matters to you? Maybe you've heard.
Це первинне.
Yeah. And sometimes it doesn't have, from a person perspective, it tends to be goes so much more time if the referrals within the system. So the timing and the time has shortened as a lot in healthcare.
Це
Це
правильно.
результат домовленостей на цьому лідерському рівні, правильно? Тобто це ж не Міністерство охорони здоров'я каже, що давайте тепер ви більше.
Мотиваційні стимули для первинної ланки.
Робити так.
Інна, мотиваційні стимули для лікаря, робити саме так, витрачаючи час. Якщо вони, чи це ті просто, я розумію, або ми говоримо, що це...
Нас то якраз це цікавить.
Да,
Замотивувати
Це треба з лікарями говорити, я так думаю. They are asking about what motivates individual doctors actually to
in primary care to do this.
kind of approach.
I would say that it's mainly to segment doctors on when is the doctor as much needed as possible compared to what other competences can do also.
Це також сегментувати, де лікар є найбільше потрібен
I would say.
в порівнянні з іншими послугами.
Yes,
Yes, maybe you can
from our perspective, when working with the different primary care centers that we have,
Працюю з
we're based in a very
Можливо, це
remote and
тільки
rural
питання етичного
area.
ставлення до професії.
And in that case, we see that the doctors are
Етика працює на
very
10%.
keen on
10%
taking this responsibility because they are becoming more educated. They learn from other specialist doctors at the university hospital, in our case, known as university hospital, how to treat the patients, and know they extend their knowledge as a primary care GP, becoming then be allowed to be in contact with these specialist doctors, but also provide better service to their patients. So the primary care reform, high quality local healthcare, I'm not sure what the name is in English, is very much about centering everything around the citizen and make sure that the door that they go into is the primary care center can open the right doors to the patient and plan everything better for the patients it doesn't have to be that the primary care doctor takes the call to a specialist. It could be alternative models that are being developed inside the system. But remember now, this is not only a primary care reform and a specialist care reform. This is a healthcare and social care reform. So very much it's also about organizing and planning how to collaborate better with the municipal level, the local level. That has fairly big part of the legislation of healthcare legislation are being performed at the local level by the municipalities, but they are not having any doctors. So the doctors are always inside the regional healthcare system, and they need to find models to collaborate, to provide services as efficient and as good as possible for the citizens. We will show you examples when you come up, so you could see this in practice. For instance, it was mentioned by you the elderly care centers that we have, and the responsibility that the municipality has to do, to visit the patients, and they do this then with a doctor from the primary care, in our case. But in our case, this doctor is one doctor visiting hundreds of patients online. They bring the doctor in an iPad, visiting the patient face to face, but through an iPad, with municipal nurses. And what we learn from this is that the municipal nurses feel much more safe having the same doctor every time, meeting the same patient, than having different doctors that are having short-term contracts coming to visit the patients physically. So even if the doctor is online, we haven't done studies on this, but we believe that the patient's safety and the patient's experience of healthcare becomes more appreciated. So using digital tools in our case helps provide access to healthcare. But it's also a way of organizing this primary care reform that we are talking about. So it's not only about primary care and specialist care, or hospital care and specialist care. It's also about organizing a model that works with the local municipality and the services that they are providing the citizens. But you will see examples of this, and you can ask them examples when you come up.
Okay, thank you.
Thank you very much.
Thank you.
Okay, yes, please.
We